to today's ATI session. My name is Carol Wang. I'm a transplant nephrologist in Calgary. I'm really excited to be moderating today's session. Before we start with our talk and featured speaker today, I want to start with land acknowledgements. So we acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. In addition, we wanted to thank Paladin for their support of the ATI seminar series. There's a couple of exciting events that are coming up that we also wanted to bring your attention to. Firstly, we're excited to invite you to register and submit abstracts for two upcoming events, one being the International Symposium on Systems, Immunology, and Transplantation, Advances, Challenges, and Opportunities, which is co-hosted by the Alberta Transplant Institute, or ATI, and the National Institute of Allergy and Infectious Diseases, taking place in Edmonton, Canada. The link is posted. In addition, the ATI Research Day is also coming up. And the registration link is also posted in the chat. So please take an opportunity to register for the exciting events. So moving on to our talk today, I'm really excited to introduce our speaker, Dr. Seychelle Yohanna, who is an associate professor in the Department of Medicine at McMaster University and a transplant nephrologist at St. Joseph's Healthcare in Hamilton. After completing her internal medicine, nephrology, and kidney transplant training, she obtained a Master's of Science in Quality Improvement and Patient Safety from the University of Toronto. Her focus is improving access to kidney transplantation and living kidney donation for patients in Ontario with chronic kidney disease, and is the provincial medical lead for kidney transplantation at the Ontario Renal Network. She has a particular interest in removing system barriers to living kidney donation and leads the Hamilton one-day living kidney donor assessment clinic. So she'll be giving us a talk on improving the efficiency and patient-centeredness of the living kidney donor evaluation. And Seychelle, you have the floor.
Awesome. So thanks everyone for inviting me to speak here today. This is a topic that is quite near and dear to my heart. I am always in awe of those who come forward to donate a kidney, and their experiences become very important to me in my career and in my life. So I'm going to be talking to you today about our journey in Hamilton to improve the living kidney donor evaluation. So I have no conflicts of interest to declare. I'll be going through essentially describing to you all what the impact of a long donor evaluation is, what our journey was or how it has gone to make it better, and then I'll speak specifically about the one-day donor clinic. So I don't know how many people on this call are going to recognize this young woman here, but I'm going to ask you all to picture it. Hamilton, 2015, I was a transplant fellow, and I was just falling in love with transplantation. I think all of you can appreciate how a kidney transplant really changes someone's life, really can change the trajectory. It allows them to feel healthier, contribute to society, go back to work, enjoy their family and friends. And I'm a little bit of a sap, and I love a love story, and I love a happy ending. And for me, this was how I fell in love with transplant. I also was surrounded by incredible people who were so passionate about transplant. But I did recognize very early on the inefficiencies and the difficulties that our patients, suffered from as a result of the system that we produced as clinicians, very well-meaning clinicians, but still. So this was me as a transplant fellow in the fellow's office. And, I was very excited to begin this journey of transplant. As I said, I really was in love with transplantation and how it improved people's lives. But similarly, I had a similar passion for sort of radical common sense. And this is where I began my journey in learning about the science of quality improvement and patient safety. And one of the sort of the foundational elements of quality improvement is that everything we do really should be centered around the triple aim. So, as we're designing healthcare systems, we should always be looking to improve population health, improve the experience of care, and reduce healthcare costs. Now, this triple aim has now expanded to a quintuple aim, but I still kind of hold true and think about how transplantation, for me at least, is really like a very pivotal example of achieving the triple aim. And I just can't think of many other medical interventions alone that achieve a triple aim as transplantation does. So this is kind of where my journey started. I was in love with transplant, and I also wanted to improve the system. So the living kidney donor evaluation is pretty similar across Canadian transplant programs, albeit there's some differences. Essentially, it's a series of questionnaires, lab, urine, diagnostic test, consultations with clinicians. And we don't really have a national benchmark, like how long should this take, or how many visits should it be? But what we do think is that it should be completed within as little time as possible, but also meeting the needs of the donor candidate, the intended recipient, and the healthcare system. But as I mentioned, there's no national benchmark, and it can take really anywhere from 1 month, as little as 1 month, to as long as a few years to complete. And in other areas of outside of medicine or outside of healthcare, if we wanted someone to do more of something, if a business wanted you to buy a product or engage in an experience, they would be looking to create the most customer-centered experience that they could think of. They would think about your comfort, your happiness during that activity, or with purchasing that product. But in healthcare, we haven't really designed the donor evaluation with the donor's experience in mind. And we all know we're all trying to increase living kidney donation. And I would just, stop and pause to think, like, if we want more people to do something, don't we think that we should focus on, their experience going through the process? So, we all know we're all trying to achieve a preemptive transplant if possible, but I always tell my patients, because I see recipients and donors. So when I see recipients and they have a living donor and they're preemptive, I always tell them it's like it's like the stars have to align. And we oftentimes, when we're trying to achieve a preemptive transplant, for one reason or another, we fail to achieve a preemptive transplant. So the reason being is that you have two different evaluations occurring, sometimes simultaneously, sometimes one in advance of the other. But having those evaluations completed and the donor and recipient approved at the same time, without any medical issues arising in either one, and trying to time that transplant appropriately, oftentimes we fail. And what was shown really, Stephen Habus did a study looking at a subset of living donor transplants where the recipient was a first-time kidney transplant recipient, was not on dialysis when the evaluation of the donor candidate that ultimately ended up being their donor had already been, well underway. What they found is that for those subset of living donor transplants where they were preemptive and a donor had already been in evaluation for several months, that 35% of those failed to achieve a preemptive transplant. So it's not just in our program. This is, something that occurs across the board. And of those that failed to achieve a preemptive transplant, 26% of them initiated their dialysis urgently in hospital. And it was another average of 8.8 months until transplant, which all of that cost the healthcare system $8 million in mostly dialysis costs. So while we're always aiming to achieve a preemptive transplant, oftentimes we're unsuccessful. And, one of my goals is to make sure that the donor evaluation, the inefficiencies of the donor evaluation are not contributing to that. So from the donor experience side, we want to make sure it's a very a smooth and good process for them, but also for the recipient, we want to make sure they have the best possible health outcomes. And either they can receive a preemptive transplant, or at least they can minimize the amount of dialysis they have to receive. So when we have a long, inefficient donor evaluation, it impacts both the donor and the recipient. For the donor, oftentimes, they get tired of the back and forth, the coming back to the transplant center, doing another test and then another test. And sometimes that's the reason they drop out. The donor has to take days off work. These are usually young, healthy people who have families and jobs and obligations. And we're asking them to come back and come back again, and to go to this lab and to do this test and come back for this x-ray. And that becomes a huge burden in their life. And also, all the while that they're going through this, they're not sure. Like, they have no idea. Are they going to donate? Are they not going to donate? Are they going to be able to help their loved one? Can they book this vacation next summer or not? Basically their life is on hold. And for the recipient, as I just mentioned, oftentimes they fail to achieve a preemptive transplant. They have to have access created. There's, they have to undergo dialysis. There's healthcare costs associated with that. And in fact, one of the things that we see often is that if they're waitlisted, which oftentimes they will be, they will receive a deceased donor transplant instead, which takes a kidney out of the system. That's an outcome that none of us, would like to see, as there are several people waiting on the deceased donor wait list for a kidney. So both the recipient and the donor have a very difficult time navigating the process. Despite our very best efforts and all of our well-meaning, actions, they still feel like this is a scary, overwhelming, disconnected, confusing, not transparent process, and they find it difficult to navigate. And this is really both for the donors and the recipients themselves. So just thinking about that, and having this in mind and knowing the impact of a long donor evaluation, I think is important. So what are the barriers to being efficient? So on the program level, we all have variable processes for intake. So how we begin the donor evaluation process. And also we have variable, I would say, rules or protocols or policies about how many donors we'll evaluate at one time, whether we'll begin a donor evaluation based on recipient criteria, like whether the recipient has been referred or the recipient has been approved or the recipient's GFR. We all have different processes in place for how we begin the donor evaluation process. All of us have testing policies or protocols, and some of the tests located within those protocols may or may not be aligned with KPD guidelines or with the best available evidence. And the way the sequence with which we design the process may make it longer or more burdensome on the donor. So for example, some programs will start with an ABO blood type or an HLA to know compatibility before they'll begin the evaluation. And sometimes just that in and of itself will add a 1 month, 1 month upfront to the process, when most donors are okay to enter KPD if that was necessary. It's also difficult to communicate between our recipient donor team to make sure that parallel evaluations occur, in parallel. Oftentimes there's fragmented communication. And from the healthcare system, I don't know how it is in Alberta, but in Ontario currently, no part of the donor evaluation is actually funded. So there's no, for all of the donors that come forward that never end up ultimately donating, that is all a significant, huge amount of time and resource to our programs. And there's actually there's no remuneration for that. The only funding that's received is when a transplant occurs. So again, if we're trying to have many, many donors come forward, and often we know up to 5 donors have to come forward for one to be approved, all of that work is not being funded. There's a lack of access to timely consultations, for example, surgery, nephrology, cardiology. It takes quite a while, and especially if patients live rurally, that is even a bigger barrier. And then in the hospital, from the hospital, access to testing or access to consultations may be more difficult if transplant is not a priority at the hospital. So if having efficient processes in transplantation and having, really highlighting transplant and doing as many transplants as possible is not a priority in the institution, it may be more difficult to gain traction and to ask for more resources to have your donors evaluated efficiently. So what we did sort of at the beginning of our journey in 2016, we essentially looked at 1 year's worth of donors that came forward. And in 1 year, we had 246 donors that came forward. And what we looked at was, at that time, we used to do a telephone intake. So our donor coordinators would spend, anywhere from 5 to 45 minutes on the phone with a donor who called indicating interest in being a living donor. And within that telephone screening, approximately 20% of people were turned down right from the telephone. So either they had diabetes or they were being treated for cancer or whatnot, and they would be turned down. And of the 197 that were remaining, we would send a healthcare questionnaire as the sort of the second step, and 102 out of the 197 would return the healthcare questionnaire. So from there, 20% lost on the phone right there. And then of those who were remaining, only about half of them ever even returned the questionnaire. And then from those who returned the questionnaire, about half of them would be eventually approved, and the other half would either, be declined or withdrew from the process. So that gave us a bit of information in terms of how many people kind of get to the end from the beginning. And this was the design of how our donor evaluation looked like. So we began with that phone call, then the health questionnaire at the top. We would send patients for labs, chest x-ray, ECG, nuclear GFR. If they were older than 50, we would do cardiac testing. Then they would meet with the nephrologist. The nephrologist would, deem them sort of preliminarily medically acceptable. They would have a CAT scan. They would, in some point of the process, they'd meet with a social worker. Then they would meet from the surgeon. If they met from the surgeon, they met with the surgeon and the surgeon approved them, then they had this final approval. And from final approval, they would have their pre-donation visit with the nephrologist. They would see anesthesia, and then they would donate. So what we knew, when we did our audit, what we knew is that from the time the donor contacted the program to the time they were approved was approximately 8.8 months. And from the time that the donor contacted the program until donation was approximately 10.1 months. And the average number of visits was 9. But those number of visits was anywhere from 7 up until 15. So that's visits to a testing facility to complete the evaluation. And this is actually in line with another study that was done by Stephen Habous, where they looked at living donor evaluations in Canada and Australia. And what they found was that the median total evaluation time was 10.3 months. Which is sort of in line with what we found as well. But so about 10 months to be approved. So we did a donor evaluation survey after, and we did this donor evaluation survey for donors who had donated 3 months post donation. And there was 44 donors in this received this survey. We had a 29% response rate. And 1/3 of the donors said the process took too long. One donor said that I found out when I submitted parking receipts for reimbursement that I visited the hospital 15 times. Another one remarked to speed up the process. Long time from start to finish. And so when I think about this, I think about, pregnancy. If there's anybody on this line who's been through pregnancy, the pregnancies also, they lie to you and they tell you that it's 9 months, but in fact, it's 10 months. So the time it takes to evaluate a living donor is essentially the same amount of time that it takes to have a baby. And for anybody, any mothers on the line, you know that that last period of time, you're dying to just get it over with. But just like mothers, donors seem to forget how bad it was. When a mom sees the baby's face, all of the last 10 months are gone, and she melts and she falls in love. And if you ask a mother whether she'd do it again, of course she'd do it again. Well, most of them say they'd do it again. And similar to donors. So even though we asked donors, and there were many that said the process could be better, the overwhelming majority of people that have donors, when they look back, they say they would do it again. That they felt happy that they could help their loved one. And I found that donors, and this is another reason why I'm always in awe, that no matter what we threw at them, they'll always say, yep, okay, I'll do that next test. Yep, sure, I'll come and do this. And they do it with just pure, altruistic love and care for their recipient. So, similar to mothers who really go through a lot for their babies. This slide is just to show you that, not for you to look at the content, but in order to understand how to improve your process, it's really important that you understand the actual process. So as an early staff, I thought I knew what the donor coordinators did, but it wasn't really until I sat down with them and really shadowed their every single move and every single decision point that I really understood what exactly we were doing in the donor evaluation. So the first sort of rule for improvement is you have to really understand what your current process is. So what did we do right from the outset? We tried to streamline our process. So we had a lot of back and forth. There was this telephone screening that, as I showed you, half of the people who passed the screening never even returned a healthcare questionnaire. So right there, that showed us that that's a lot of time our donor coordinators are spending on the telephone, and that's resulting in very little kind of, I guess, you're not getting very much out of it because half of the people are not moving forward. So we removed that telephone screening and we moved everything online. So we would do everything. We used to do everything by snail mail, mailing requisitions, mailing consent forms, mailing questionnaires. So everything, we put everything online. We moved to email, and eventually, now that we have Epic, it's through my chart or what we call my dovetail. And we now really communicate mainly electronically with donors. We started pre-booking appointments. So instead of waiting to see the nephrologist before we would book the CT and surgeon, we just booked them right from the beginning. So they would sort of fall just after the nephrologist appointment instead of several months down the line. So we did that, and then we removed the need. We used to start with an ABO in order to sort of begin the process to know whether they were an ABO and an HLA to know whether they were compatible or not. And then we removed that because what we found is that I would say 98% of donors would agree to go into KPD once that was explained to them. And then we eliminated waste. So we had a lot of additional tests that were really not evidence-based. So for example, we used to do a 24-hour ambulatory blood pressure monitor in every individual over 50 years old, whether they showed up to clinic with a blood pressure of 90/60 or 150/90. So there was some practices that had been handed down, I guess, over generations, and no one ever really stopped to think, like, do we really actually need to do this? And how ridiculous is it to put a 24-hour ambulatory blood pressure monitor on someone who's like like normotensive? And then, that's another, they go off with this thing on, they got to bring it back the next day. We also used to do an automatic cardiology referral to everybody over 50. We no longer do that. We stopped making people do the oral glucose tolerance test. We now only do it if there's risk factors or if there's abnormalities in their A1C or fasting glucose. We got rid of, we used to do a stone workup on every single donor, whether they had stones or not. But we would do that. And so these were things that we just thought, like, why are we doing this? And so we removed it. And we did this for all donors. And this was very helpful for us. And then it was just around that time, and some of you may be familiar with this clinic in Ireland. It was published in AJKD in 2016, I believe. And essentially it outlined the adoption of a one-day donor assessment model in a living kidney donor transplant program. So it was a quality improvement project. And essentially they implemented a weekly clinic where they evaluated 2 donors per clinic, and the study looks at the outcomes between 2010 and 2015. So this is what their day looked like. You started at 8 a.m. with blood and urine tests. You went for an ultrasound, an ECG, an X-ray, nuclear GFR, and renal scan. You then saw what I'm assuming is a nephrologist or some type of physician. And then you had your CAT scan after, and then the surgical consult would be done sort of on at a different time, I think a few weeks later. And you would also see what they call was an independent assessor, which is similar to our social work. So they looked, so this clinic, after the clinic occurred, there was a multidisciplinary meeting to review the donor. The surgical consult was done after the clinic, and then as well the independent assessor, which is similar to what I think our social work would be. And the total expected time to complete the evaluation was about 2 to 3 months. So from this clinic, in this study, they had 431 donors complete the one-day donor assessment over a 5-year period. And 2/3 of the donors ended up donating. At the time of the study, 3% of them remained active or approved, but hadn't donated yet. And 31% had exited the program. And the reasons for non-donation are shown up here in this table. So for the most part, either donors were unsuitable or an alternative donor was found. In 17% of cases, the recipient was unsuitable. 13% of the donors withdrew. 4% of the recipients withdrew, and 1% of the donors became pregnant, and so were not eligible at the time. So this graph here just shows you from 2000 until 2015. Essentially, this is the per million population living donor transplants. That's the orange bars. So as you can see, up until 2010, up in 2009, there was sort of just above 10 per million population living donor transplants. And then in 2010, from 2015, there's this huge rise in the per million population number of living donor transplants that you can see. And you can also see in blue the prevalent dialysis population is increasing. Now, in this paper, they attribute, obviously, this huge rise to the clinic. I think we can all agree that there are likely some other factors aside from just a one-day donor clinic that would increase living donation numbers with this magnitude. Similarly, their proportion of preemptive transplants increased. So you can see the orange bars within the purple bar are the proportion of the living donor transplants that are preemptive. So again, up until 2009, a very small proportion are preemptive, but then you can see from 2010 onwards, there are more living donor transplants, but more preemptive transplants, sorry, and a higher proportion are preemptive. So they go from, less than 10% in terms of preemptive transplants all the way to greater than 50% in 2015. So overall, that one-day donor clinic was, it was a positive study. I think there were some stretches in terms of, the association of the clinic itself with the outcomes that they saw. But, it was happening at the same time that we were trying to improve our donor evaluation. So we started to have our own sort of stakeholder meetings. So we outlined the results of our donor survey where donors were saying that it's taking too long, that they're paying for parking 15 times and whatnot. And we started to create a story that we shared with all of our hospital partners. So the donor evaluation is obviously done across the hospital with diagnostic imaging, nuclear medicine, social work, cardiology, radiology. So there's multiple departments, and we essentially just started sharing the transplant story. So, what were our donors going through? How was this impacting their lives? How is it impacting the recipient's lives and health of the recipient? And we really outlined what was our ask from each department in order to create a one-day donor clinic ourselves. So in 2019, with the help of a huge team, we created our own one-day donor clinic. And you can see out here, this picture is taken during the pandemic about a year later with the majority of the team here. It really was a huge team effort, but something that the hospital has really been so incredibly proud of, and we're so proud of as a program. So we have our clinic now once a month. We've had it since 2019 in March. We essentially evaluate 4 donors in each clinic, and it's a celebrated success. We have patient partners or transplant ambassadors that come to the clinic and meet with our donors and help provide the patient's lens to donation. As well as a huge team that facilitates this day. So our new one-day donor pathway it's not available for all of our donor candidates. We evaluate just 4 donors a month this way. So it's about a quarter of our evaluations. So the one-day donor pathway is that the donor candidate submits their online health questionnaire, and we use the KPD questionnaire just as a lot of programs do. The donor coordinator reviews the questionnaire, and if there's no contraindication, they arrange screening lab and urine tests over one visit to a lab at a local lab. And once the donor candidate completes that screening lab testing, and the donor coordinator reviews it and decides whether there's any contraindication to entry into one-day donor clinic. So if, for example, they have a low GFR or, their fasting sugars are high, they probably wouldn't be offered a one-day clinic option unless it was run by the nephrologist and we agreed to let them in. Routine cancer screening is not done in this clinic. That's obtained through their family doctor, so it's outside of the clinic. So on the one-day donor clinic day, they have their HLA lab drawn. They have their HLA labs drawn. They have other sort of day 2 labs, what we call. They do an ECG, a chest X-ray, a nuclear GFR, a CAT scan of the kidneys. If they're a man over 50 or a woman over 60, then we do a exercise stress test and an echocardiogram. They receive education from the donor coordinator. They meet with the transplant ambassador, as I mentioned. They meet with social work either on that day or on the telephone in advance of the day. And then they see the nephrologist and the surgeon. Those are the kind of the 2 final parts of the day. And then after the one day, we always leave the one-day donor clinic saying, okay, so we think you're a good candidate, but we do have a multidisciplinary meeting about 1 or 2 weeks later to sort of make a final decision. And this is mostly required because many of the tests that we do at the One Day Donor Clinic don't have a we don't have final results, final reads of scans before the end of the day. Obviously, if there's anything uncovered in that day, so like a liver cyst or something that needs additional follow-up, that testing is not within that day. We have to arrange it on a different day. And so this is what a sample schedule looks like. They will start as early as 7:30 in the morning and finish at 4 o'clock. There are a few breaks in there. And we do sometimes, like, aside from the ECG echo, stress test, chest X-ray and CAT scan, nuclear GFR, some of the other stuff can be shuffled here and there if we need to. But the first part of the day and all of the checkbacks with nuclear medicine, those are set in stone. So in terms of successes and challenges, donors love this day. They're very thankful to be able to participate in this day and get it all done in one day. It's been a wonderful example of teamwork and collaboration across the hospital. Like I said, it's been celebrated at the board level of the hospital. It's been celebrated in many forums, provincially and nationally now, and so we're very happy and proud of it. We've dramatically reduced the number of visits, and the time to decision, even if they're declined in the One Day Donor Clinic, at least they know faster so that recipient can move on to the next potential donor. So it's been really great. And the other thing that I think has come out of it is that really the process for those who don't go through the One Day Donor Clinic, we think that the process is actually faster for them as well now because of all of the changes we've made in terms of streamlining and making sure we're really only ordering the tests that we need. In terms of challenges, I mentioned that the final reports of tests are not available on the same day. So, sometimes we're left not knowing whether a donor is eligible, and there will have to be additional tests if additional abnormalities are found. Getting the surgeons to come, they're very passionate about the One Day Donor Clinic, but it is hard to get them scheduled into the clinic because their call schedules and their surgical schedules are out at a different time. So that is one of the challenges, but they always someone comes. And in terms of, we don't have a very sort of real-time way to assess, at least at our institution, whether this is, resulting in improvements in terms of overall time it takes. So we don't have any current method right now of monitoring the total evaluation time at our institution. So with that said, we did apply for a grant to the Kidney Foundation to evaluate the outcomes of the One Day Donor Clinic. We were very lucky. I was very lucky to receive this kidney health research grant, and we're in the midst of doing this study and it has two sort of objectives. One is to compare the outcomes of donor candidates who go through the One Day Donor Clinic versus contemporary controls, so people who didn't go through the One Day Donor Clinic, and then compare it also to historic controls, so donors who underwent the evaluation before we implemented the One Day Donor Clinic. And so with those three groups in mind, we're going to be looking at several process and outcome measures that were identified in a RAND modified Delphi study on donor quality indicators. And then the second part of our study that we're undertaking is a qualitative assessment of healthcare worker and donor experience in the One Day Donor Clinic, with a specific lens on barriers to the donor evaluation experience from those who are in an ethnocultural minority. So very excited to hopefully have results from that study in the coming year. But I also recognize that a One Day Donor Clinic is really just one piece of the puzzle. There's an entire recipient assessment. And although people always ask me, when are you going to make a one-day recipient clinic? I recognize that it's not as simple for recipients, as their health is usually not as good as the donors. And so it's not as simple as to put together a one-day recipient clinic, although we do need to shift our focus at some point to the recipient assessment as well. That's in the coming years. It's so I say that because, oftentimes we'll see people in the one-day donor clinic, and we can get them done fast, but if their recipient is not referred yet, or the recipient is referred late, the fact that we can do the donor quick is just not enough. So I'll give you an example. I saw a 43-year-old female who had a history of cervical cancer in 2010, but fully cleared from that, wants to donate to her brother, who's blood type O. I saw them in the one-day donor clinic in December 2021. She was approved December 21st, 2021, a few weeks later. But the brother was still completing their referral testing, hadn't even, had their first transplant evaluation consult at our center, and the EGFR is less than 10. So, I mean, we can work up donors fast, but if the right hand doesn't talk to the left and they're not working in parallel, we're still not going to see the best possible outcomes that we can. So that's just to say it's one piece of the puzzle, and we do need to work on the other end as well. When we looked at our referrals, what we found is that many people who had a living donor were actually already on dialysis at the time of referral. So 1/3 of them were already on dialysis at the time of referral, meaning we never had the opportunity to achieve a preemptive transplant. And no matter how fast we'd go, it really didn't matter. Well, I mean, it matters in other ways, but it didn't matter in terms of achieving a preemptive transplant. And a large majority of them had a GFR that was less than 15, which makes it difficult sometimes when you don't have a lot of runway to achieve a preemptive transplant. So I'll just now talk a little bit about what we're trying to do nationally. So this is what we're trying to do at a program level as the one-day donor clinic, but I'm also interested in trying to help us nationally as a collective group of very passionate individuals who want to improve the living donor evaluation. I'm hoping that we can come together and really agree upon some national guidance on how long the donor evaluation should take. So we held a Living Kidney Donor Consensus Conference last September, and some of you on the line may have been participants at that conference. But I just wanted to tell you a little bit about that. So essentially, this conference had two objectives. First objective was to define key elements of a high quality donor evaluation, considering the 6 domains of quality. And objective 2 is to select at least 5 consensus-based metrics of a high quality evaluation, and to establish national benchmarks for these metrics. And we had this meeting September last year. So this is just a high-level overview of the process that we went through. We had multiple working groups to really try to have a comprehensive understanding from the multiple perspectives of all of our stakeholders, including our patients, on what are the ways that we need to consider the living donor evaluation and how should we improve it. So we had that consensus conference last year, and it was a huge success with, at least 100 people, with many administrators, physicians, nephrologists, surgeons, patients on the line. And it was a really great dialogue between us all. And we were able to vote on a number of recommendations to improve the living kidney donor evaluation, to define it and to improve it. So in total, we had 42 recommendations that were achieved consensus in the first round. And then after a second round of eDelphi, we had 43 recommendations total. So I'm not going to go through the recommendations that came out, but I just selected a few from each of the categories that we did reach consensus on and that were thought to be important. So for example, under general guidance recommendations, it was thought that the number of tests performed in an evaluation, the number of days between tests, and the time needed to complete the evaluation should be significantly reduced. But that also there needs to be adequate resources and funding, as well as an effort to strengthen provincial reimbursement programs to match the expenses incurred by donors. And then recommendations for improving the evaluation process, really that we should be looking to have a consistent protocol across provinces, and that we should be limiting repeat collection of blood and urine tests and trips to a testing facility, and that we should all be looking at our evaluation processes to make sure that we're basing them in evidence, or where evidence is lacking based on pragmatism. And then finally, in terms of metrics, it was agreed that we'd all should be looking at demographic information, that those equity factors such as sex, race, age, and in terms of any metrics should have those included, and that really to improve the quality of that evaluation, living donor programs should measure the number of candidates that come forward and really where they're dropping out at each step of the process. I'll just skip over that last slide, but just to say that also, with this said, Ontario has created a provincial living kidney donation working group. And this has been done partially with my role with the Ontario Renal Network and Trillium Gift of Life. And we have now membership from all of our living donor programs, and we are working on a funding model to fund living donor evaluations, which I think will be really helpful to programs, as well as sort of like a best practices or standardized protocol. And then I should also say that now 3 Ontario programs are offering the one-day donor clinic out of our 6 adult transplant centers. So we're making some progress there. I just want to summarize to say that donors deserve a very good experience. They're coming forward altruistically to save a life. They are saving a life. And in other areas of the world, when someone is coming forward to do something so altruistic, we really need to be considering their experience and also the outcomes of their recipients. It's a process, so I would say start by looking at all your testing and the sequence with which you require the tests, and do a step-by-step process map to look at where all of the inefficiencies lie. Consider an expedited assessment. I really hope, that's my hope for programs across Canada, that we all have an expedited assessment that focuses on reducing the number of visits and reducing the time it takes to a decision. And then stay tuned really for the next steps of our consensus conference, because we are going to be, having additional work now in order to implement some of the recommendations that came out. And just to say, for Paul, if anybody knows Paul Batalden, every system is perfectly designed to get the results it gets. So if we want more donors to donate, we really need to focus on improving the system that we create for them. And that's it. That's all I have. Thank you.
All right. Thank you so much, Seychelle, for your very insightful talk on this very important topic. And I also wanted to congratulate you and your team in establishing and implementing the first one-day living donor program here in Canada, as well as for your leadership in the consensus conference in establishing living donor metrics. I wanted to kick off the question and answer period with a question of mine. I was wondering if you can perhaps share with us or elaborate on your experiences in implementing the One Day Living Donor Program. What was the biggest barrier or hurdle that you and your team had to overcome in the initial phases in engaging stakeholders as well as eventually implementing this program?
So I would say that we did this without there was no money, there was no additional funds, nothing. Like, it was just basically asking. And I would say pleading a very strong case in terms of like, we use patient stories. We literally told them how many days, how many times. And I think all of us who go into healthcare at the end of the day, like we're all the same. We all want better for patients. Like there's something innate about us. You tell a patient story, it can be very convincing. And where I thought, diagnostic imaging would say, hell no, you're not going to get 4 CTs a month. They
Mhm.
actually were like, yeah, sure, Dr. Johanna. Yeah, we can do that. Like, so it was actually, I thought that was going to be the barrier, like getting the 4 echoes, all of the diagnostic tests. And I thought that was going to be the big barrier, but it actually wasn't.
Mm.
Programs ended up being more than welcoming and open to the idea. And I don't think we're a center that has any more CT scanners or whatnot than other centers. I think we're like an average center in Canada. So that's what I thought would be the big barrier. What ended up being the big barrier was a little bit of like I was really hung up on the fact, like, I wanted those test results on the same day. I wanted the donor to leave knowing either yes or no. So I
Yeah.
wanted radiology to do like quick reads. I wanted nuclear medicine to tell me right now what the GFR was. And once I got over the fact that that wasn't going to happen, because it wasn't. No matter how many times I asked, they weren't going to do those expedited reads. So once I got over that, then I think it was a lot better. But that was sort of the one big thing I really in my head. I wanted it to be done in one day, like exactly one day. And then the second thing was really the surgeons. So I love the surgeons. I love them all. We have 3 amazing surgeons, but getting them to, know their schedule and be there is difficult, especially like if they're on call or if there's deceased donor transplants happening or multiple deceased donor transplants happening. So they can be a little bit unpredictable. So that I would say that was but they're more than like they come and they're happy to be there when they can. Phil?
Thank you very much for your insight.
Thanks.
Dr. Halloran, go ahead.
Can you hear me?
Yeah.
Listen, I'd like to congratulate you on this. I was born in St. Joseph's, and my aunt was a dialysis nurse there, and all the achievements of St. Joseph's I always applaud. And I'm still a Tiger Cat fan, incidentally. So I would like to raise something slightly uncomfortable based on some of my experiences. It was not comfortable for me, but it may make you uncomfortable. When you're talking to a potential donor, there are occasions when you feel an element of coercion. They feel that their relationship with the recipient is putting them into a situation they don't want to be in. Now, when I've sensed that, first of all, we're not legally, you should not be participating in a situation where there is coercion. And secondly, I would give them a hint that we would get them an out, like finding a red cell in their urine, and declare them unsuitable. So you're interfering with a relationship between 2 individuals potentially in a way that could harm that relationship. And so I know this is a little bit uncomfortable, but how do you feel about that? Do you actually advise the physicians to try to get any sense of coercion and see if you can engineer the person out of a situation where they're feeling coerced?
Yeah, that's a really good question. One that's not really, I like the one day donor clinic is interesting in that it speeds up this process to the point that uncomfortableness could get missed. But in every donor that I see, it's part of my sort of spiel. I tell them that they always have an out, that we just say they're medically unsuitable. But I do find that I would say the donor coordinators, the social workers, and then myself, we usually find like that we have that spidey sense. If it's not obvious, we do sort of dig when we start to kind of hear certain things that sound, and we will dig and we will ask. And whether it's a 1 day donor clinic or whether it's the usual care assessment, we will always, if we have that feeling, we'll give them the out. And if they don't take the out, we actually send them to like our psychologist to see kind of what they think. Because sometimes Phil, when you give them the out, they're still not, they don't take the out. So sometimes we'll have our psychologist assess them, and then they'll just say no. And then you know, it makes it easier for everyone. But we do have that come up.
Well, I guess I'm specifically referring to the fact, will you give them an easy medical out so that they can, you can.
I will if they accept that. If they accept that. So there's a question in the chat, which 3 Ontario programs? So it was us first, and then Ottawa did it next. And then I'm so happy to say London just started, I think, a year ago.
I'd just like to congratulate you. This is something that every center, United States, Canada, and elsewhere should be doing.
I really hope that happens. Thank you so much.
I think Mike and Linda also had a question.
Maybe it's Linda, yeah.
Yeah, it's Linda. I'm actually a living donor. It was 6 years ago today, actually, that I donated to a friend. And I had quite, I actually got upset with the doctor who I was seeing. I was actually traveling about 700 kilometers round trip to every appointment that I couldn't do locally, because my friend, he lived far away from me, and so I went to his, like where he was always.
Yeah, you went to their center.
I went to their center, and as I said, it was like 350 kilometers one way. And I'd asked, okay, can I have as many appointments as possible in one day? And I went down 3 times for one appointment. And one was a allergist appointment, which there's allergists everywhere. And the allergist actually asked me, don't you have one locally? But the other part with the nephrologist I was seeing, he was almost to the point, like it got to the point I told him, look, I'm here. I'm dedicated. I want to do this. Because he was almost shoveling it down my throat. Why would you want to do this? Like you're crazy to want to do this. And he was going more the like, you know, more than giving me an option if I didn't want to. It was pushing me, almost pushing me like, why would you want to do this? You're crazy. So that question is out there. I know in my sense, it was almost too much that way.
Yeah, this is a story that we've heard now a number of times, Linda. It's really sad that you had to travel 3 times for one appointment. And you know, no one should have to do that. And like, to save a life, nothing for yourself. Like you're getting nothing out of this. Other than, you know, just the happiness of seeing, you know, someone you care about healthy, but you know, like I just can't imagine how we design healthcare like this.
I did have some days where I did have a couple of appointments together.
Yeah.
It was 3. It ended up that I had a lot of travel time that wasn't covered with Trillium after my donation, which to me, like that was just a cost of doing it. I promote organ donation a lot. I'm actually a 4-time living donor.
Oh, wow.
My husband is a heart recipient. So I'm just going to stand up a little bit and just show my shirt.
Oh, thank you so much for sharing. I see there's a lot of questions in the chat. I'm not sure, or comments in the chat. I'm not sure if we have time for those, Carol, or anything.
Unfortunately, I think we're on the hour, but thank you very much, Linda, for sharing your experiences, and certainly highlights the importance of, you know, the need to improve our living donor assessments, and such as through a 1-day living donor program. And I once again, I wanted to thank Dr. Seychelle Yohanna for sharing your wonderful experiences, as well as congratulations on all the successes with this program. And I also look forward to the study results on donor outcomes as well as experiences as well.